Our next speaker is Dr. Jeffrey Crooms. Dr. Crooms is a community surgeon, and obviously we cannot talk about laparoscopic cholecystectomy without involving the experience of many of you surgeons in the community, and in our task force we have done so. I just want to mention that before meeting Dr. Crooms in person, I met several of his patients that spoke extremely highly about it and piqued my interest. Who is this guy? Dr. Jeffrey Crooms.
Thank you very much. I'd like to express my thanks to SAGES for having the opportunity to be here. I am just like probably the majority of you. You all have a very busy practice. Just like we were trying to get ready to come here Tuesday morning, Monday was a typical schedule of several cases thrown in with an emergency GI bleed requiring a significant amount of blood and time, and 3 cholecystectomies, all of which I thought would be fairly straightforward. One was a gentleman who had no prior surgery. Unfortunately, he started hurting the night before and came to the emergency room before coming upstairs. The next one was a young lady who did not want to have a scar for her gallbladder, as I'm sure y'all have had that happen to you. And the third one was a lady who had had a gastric sleeve procedure about a year ago and also had an abdominoplasty. All of those you think are, initially did not feel those patients were going to be anything to be significantly about, and all of them took well over an hour to get done due to the inflammation that was there and what we run into every day. I do have no disclosures. A little bit, that just gives you a little bit of my background. I went into private practice in 1988 and performed the first laparoscopic cholecystectomy in North Florida, where I'm from, in May of 1990. Our indications for doing operations are similar to any of those physicians that have stood before you today, and these are what we commonly will see. There's nothing new about any of that. Also added in there certainly is gallstone pancreatitis. Our operations are done, most of them are done electively, some are done emergent and some semi-emergent. For a lot of us, our emergent operations may go away. You may be in a facility in which you have an acute care surgical service, and they are taking away many of the acute operations that you may be involved with. That is something that I would ask you to think long and hard about if you want that to happen. Fortunately or unfortunately, I still cover the emergency room and see a lot of these acute cases. The different surgical techniques. How many people out here do a single-site cholecystectomy? Raise your hand. There's more and more pressure on us about how we cholecystectomies over the years. Certainly, for those of us that have been around longer, we were trained with an open cholecystectomy. Laparoscopy came in our time after our residency, and we've learned that, and that certainly is the way most cholecystectomies are done today. And they're done with ports of 1, 2, 3, 4, or 5 ports that was mentioned. That is, there certainly are some times when you're going to do a significantly large patient that you need extra retraction in that 5th port, and it's not a sin to place that. Single-site cholecystectomy, as I said, patients come in and say, I don't want anyone to see my scar. And how do we get about that? So that is more pressure on a community surgeon. The robot is out there as well. How many of you are doing robotic cholecystectomies? Okay, still a fair number, and some, that can be done multi-port or with a single port. Notes is out there, and I don't think Notes has come to us in the community setting for the vast majority of us, but that is another obstacle that we will probably have to face as a community surgeon. And most importantly, when not to operate, that's already been talked about, of placing a cholecystostomy tube or doing a partial cholecystectomy. All of these cases are things that you will see if you have not seen already. Cholangiography is a debate every year of doing routine or selective cholangiography, and that is something that you'll have to decide for yourself. Certainly, most importantly, is the aspect of safety for our patients, and I think cholangiography does give you it does give you a better sense of seeing that anatomy. It does not prevent an injury, as has been said. Other ways to evaluate that anatomy, of course, has already been mentioned, of using intraoperative ultrasound or fluorescein-type dyes. There are special considerations in patients that you will see, and you have to be able to, as already been mentioned, to have a plan before you start. The cirrhotic patient is a very, very difficult patient, and it's not so much sometimes whether you can do that operation, but do you have the support of other staff that you will need to have. If you're in a small community, you may not have a blood bank that has enough blood to transfuse a cirrhotic patient. Morbidly obese patients also have some special considerations, and you need to be, I think, comfortable operating on those patients. No one's talked about the pediatric patient yet, but for those of us that are community surgeons, you may not have a pediatric surgeon. And so and we're seeing younger and younger patients. You see young teenage girls that have been on birth control that develop gallbladder disease. You may have a patient who's got sickle cell anemia or hereditary spherocytosis that you'll elect to do electively, and you have to be comfortable in operating on those types of patients. And that's a decision you'd like to make ahead of time versus in the night. You know, this is about injuries, about complications. There are several there. The most important is the common bile duct injury. It would be interesting, and I'm not sure that we really have a true incidence of bile duct injuries, and certainly what is a true instance of complications associated with biliary surgery. And I think that behooves us really to sit down and take time to go back, look at your hospital, look at all of the injuries and complications that can occur from a cholecystectomy. The biggest thing is prevention in these cases and being prepared to handle the tough cases that are going to come through your hospital, through your emergency room. The most important thing I will tell you that I have heard today and that is reiterated is your rules of dissection, the lateral traction, and to identify the critical view of safety. Even after you identify those, you still have to perform your operation correctly or you still can have an injury. The most important thing is, to me, is to be patient in that operating room. We all have busy schedules, and you'll run into the cases, as I ran into on Monday, and you have to back off and say, you know, the next case is going to be delayed. It may be a time, too, that if you run into a difficult case, that you call upstairs and you say, I need to cancel a case for today. I've only done that a few times in my career, but after having been up all night, operating, having a tough case, and whenever I've walked into the patient's room and said, the best thing for us today is to cancel the case. I will reschedule you. It's the best thing for you. It's the best thing for me. But most importantly, for that patient. How do we all buy into it? How do we get the community surgeons to buy into this? I think it goes back and actually starts probably with FLS. There are some hospitals that have now promulgated that anyone who does laparoscopic surgery should have taken a course in FLS and be certified in that. I think we have to continue to express the emphasis on cholecystectomy, and that was mentioned by Dr. Leahy in that slide, that it is a dangerous operation. And that for us to be certified and recertified, that we will be asked to answer correctly. There is a safety program that is in the process of being started by SAGES. You've heard a little bit about that, and I'm sure that you'll hear more about that, and that would be something that would be well worthwhile for all of us, I believe. It is not a mistake to ask for help. Whether you have a partner or whether it's a competing surgeon in the community, I think that you have to look and say, this is a very difficult case. I do need some help. Will you come in here and help me identify and give me some direction and help me with that? No matter whether you're out of your training or whether you've been in practice 20 years, you just never know what you're going to come up to on some days. The other things I've mentioned, there are other personnel that you need to have in your hospital that may be able to help you from gastroenterology or radiology. But most importantly is, I think, too, that you are going to have instances where you do need some help. And you need to have a good relationship with the tertiary center. I've been blessed to have that in Florida with Dr. Asman in Jacksonville with the University of Florida that is also a few hours away. And there's nothing wrong with calling and saying, I have this, you know, will you help me with this case? And I think that's an important armamentarium to have. Most importantly, I think that when you do any case, you want to be prepared. You want to be alert when you do that case. You want to be careful and follow through with all the rules that have been promulgated to you today. But most importantly, we do not want to do any harm to our patients. Thank you very much.